There you go. Good afternoon, Dr. Fund. How are you?
Hi, how are you? Good afternoon. Thank you, Sandra, for setting this up, and I'm looking forward to it. I just to give everyone listening a little bit of background, I've been in practice for close to 20 years. I have been working in Rockland County and Northern New Jersey for that time. Practicing my group is called Northeast Orthopedics and Sports Medicine. I've been the director of orthopedic surgery at Nyack Hospital for at least 10 years. And over the last few years, certainly at least the last 8 to 10 years, the treatment of shoulder injuries and pathology has become a passion of mine and something that obviously, as the people on this Zoom call know, is a very common problem. We all have shoulder issues, or we have friends or family that have shoulder issues. So I'm looking forward to this. The discussion is about the treatment of shoulder arthritis, and we're going to discuss what that means and the different types of treatment. But if you'd like to ask questions about shoulder injuries or pathology or any other issues with shoulders as we're going along, please feel free to ask. And as Sandra said, I would like this to be more of a town hall sort of back and forth experience as opposed to me just giving a lecture. I'm happy to stop at any time and ask questions, answer questions as we go. Okay?
Perfect. Yes, okay. Thank you very much. Now, when I was reading your bio, I
Mhm.
was very impressed because you have so many awards. So do you want to tell us a little bit about those awards?
I never like talking about my own awards. Well, I have to say that, I've been doing this for a long time, and I, we have, awards that, whether it's patient-driven awards or doctor recognition awards from other physicians. And I'm very proud of the fact that if patients are happy with the care that I give them, that they are able to express that. And whether we get awards or not, it's always nice, but it doesn't, we're just trying to do the best that we can for our patients.
Top 1% doctor in our area. I think that's very impressive. I think that people definitely would like to hear that. Now I feel like I want my shoulder to start hurting.
As you said, when you go to our website, I should have put it on here and I can give it to the people. It's NEOSM team.com. And that's the website that, I can repeat that later if you need, but that gives my bio is on there. My specialties on there. I was fellowship trained in sports medicine, which really involves more knees, shoulders, or injuries sustained, not just by high-level athletes, but by recreational athletes of all ages. And as I said, I've slanted more toward the treatment of shoulder problems over the years because it's what I enjoy the most, and it is a very common problem. So
perfect. Yes. So thank you for that introduction. It's really great. And you know what? Believe it or not, we already have questions coming. So
perfect.
Let's get to the presentation so that we can start answering all the questions. So go ahead.
You want me to start going? You want to start?
Yeah.
Okay. All right. So, it's not advancing.
The arrows, maybe?
There we go. I got it. There we go. So, just to give a background, the diagnosis of osteoarthritis, which probably almost so many people have as a diagnosis, particularly the shoulder, is what happens is that the joint gradually wears away, causing rough surface on rough surface, which leads to stiffness, pain, and a decrease in function. Joints have something called congruity, which means that they match, and as arthritis gets worse, the joints will lose their congruity. And also, the ball of the top of the arm bone is a sphere. So we lose that shape of a circle. It becomes flat, and there are bone spurs and things like that cause pain and dysfunction. Now, just as another thing, our population is getting older. And not only is our population getting older, our population is still very active. So with that, arthritis as a problem that people are coming to the doctor for, though that population of people is growing and growing every day. So as I said, as our population is getting older, but the activity level in patients is varied. I mean, I have 90-year-old patients who are running marathons, and I have, so there's lots of different, issues that we have to deal with as our population is still being active at all ages. So just as a quick little anatomy lesson, I don't want to overwhelm anyone, but basically the shoulder is a very unstable joint. It's not really a ball in a socket. It's more like a ball on a golf tee. So it's very delicately balanced. And the muscles of the rotator cuff and tendons of the rotator cuff, which are in this slide right here. So in this picture, so this white here on both sides, the picture on the left is from the front and the picture on the right is from the back. And you can see that these muscles and tendons sort of envelop that ball and allow us to move and rotate our arm. And although this talk, as I said, is not really on the rotator cuff, that's also a whole nother set of problems that maybe we'll do at some other date, because that's a very common problem people have as well. But if anyone has questions with respect to that, we can discuss that also. So again, as we said, if you look over here on the left, that's a normal shoulder joint with a nice smooth ball, nice smooth socket, which is called the glenoid. And on the right, you start to see that as that joint surface starts to wear down, either from a genetic issue or from injury or just time and activity, we develop bone spurs that can be painful, as well as the breakdown of that cartilage, causing what's called bone-on-bone arthritis, which will give pain, dysfunction, and stiffness. Again, just not to keep beating, but just want to so you understand there are different levels of arthritis. So there's different levels. So if you look at this, the top on A, that just means the cartilage is a little soft. Not terribly broken down, but it's soft. That's something called chondromalacia, or soft cartilage. And as you go from B to C to D, you start to develop cracks, then what's called fibrillations, or just more breakdown. And then in D, you have where you have bone exposed, and that's that bone-on-bone disease pattern. So how do we know you have arthritis? Pain doesn't mean arthritis. Pain can be a lot of different things. So when you go to the physician will ask you questions and take a good history as to how long it's been or anything that causes the pain. Obviously, a good physical examination is important, and sometimes a patient will say they hear crunching or cracking in their shoulder. And then we want to get, obviously, x-rays, which really helps us confirm that diagnosis. So people come in, they tell me, oh, I have pain, I have stiffness, there's this noise, it sounds like there's popcorn in my shoulder. And the things that they want to do, they can't do. That may be anything from throwing a ball to yoga to just not being able to get the plate off the top shelf. So it could be really anything why patients will say that they can't do. And, that's that decrease in function that we're really trying to treat.
Dr. Font, is this something that is going to start suddenly or like little by little, you're going to start feeling something and it's going to get worse?
So that's a very good question. There are two ways that it can present. One is that sort of more insidious or slow acting process where over months or a period of time, the shoulder hurts and then it gets gradually worse and worse. And then there are patients that, will say, you know what, my shoulder was fine. And then I fell down and put my arm out and now it's really killing me. And they come in and we get x-rays and it shows they have arthritis. Now, obviously, the little fall didn't cause arthritis. It's something that had been there, but needed to be sort of activated by some sort of small trauma. So it can happen either way. So just, to have I have patients come in and I tell them that and they're surprised that they have arthritis because it never really bothered them. And I tell them they're lucky that they didn't have pain all this time, that they actually had that diagnosis. So it can really be either way.
Mm-hmm. Thank you.
Sure. So when someone comes in, they may or may not have swelling. You don't have to have swelling when you have arthritis. There's tenderness when I touch, that certain areas may be painful. Some patients have limitations in range of motion, and some patients have pain with range of motion. You don't need to have all of these things. There could be, you could just have tenderness, you could just have limitations, but it varies depending on the patient's severity of their arthritis, as well as that just particular person. Because all those tendons I showed you, and there's all these muscles that go around, people can compensate very well for arthritis, and they may be able to live fine for many years and never require treatment. So, really the patients that I sort of treat are patients where they can't compensate. They've gone to the point where things are just too uncomfortable in their activities of daily life, and their quality of life has been significantly affected.
So I have another question from Anne-Marie in our audience.
Yes.
How can you tell the difference between frozen shoulder and shoulder osteoarthritis when it's first developing?
Okay. So the diagnosis of arthritis, and I'm going to answer that question, but if you look at this x-ray, and I'll show a comparison, but you see there's bone on bone, big bone spur, big bone spur. The diagnosis of a frozen shoulder, or what's technically known as adhesive capsulitis, really means that the shoulders become inflamed and tight and difficulty with motion. I really can't tell if someone has a frozen shoulder from that or a stiff shoulder from arthritis just looking at them. But the radiologic, that was a very appropriate question at this time, because the way that you tell is by these radiologic testing. So a frozen shoulder will have a negative x-ray, meaning there's no bone spurs, no loss of joint space, or an MRI that basically doesn't show these findings of arthritis, the cartilage breakdown, or any other deformity that can happen from arthritis. You could see, right, this used to be round. Now look at it. It's got this little thing down here is called a goat's beard. That's what that's called. And these spurs that have happened. So this person, even if they have a stiff shoulder, it's not technically frozen shoulder. It's arthritis. So that's really the difference. You know, a patient with frozen shoulder will have a normal x-ray and normal studies. And the treatment's very different. So sometimes the x-rays may, give the answer. Sometimes we need to get other testing like a CAT scan or an MRI to give us some more information, but very frequently, all you need are x-rays to make this diagnosis. People think, oh, don't I need an MRI? And very frequently, you do not. So here's another example. These are two different kinds of arthritis. So the person on the right here has this, like we had in the last x-ray, just bone on bone with bone spurring and this. And this is a little technical, but if you look at this one on the left, I don't know if you can tell, but the ball is no longer really in the socket. It's very elevated. And the reason that is because the person on the left has something called rotator cuff arthropathy, meaning that their arthritis is a result of a big rotator cuff tear that was never treated. So that's one kind of arthritis. And then the arthritis on the right is someone who just has arthritis, and those patients usually have a normal rotator cuff. So the reasons why someone gets arthritis or osteoarthritis can be different depending on their history and their findings. So although this is shoulder arthritis, the treatment for these is different. And we'll get into that. It gets a little technical, but and every specific case is a little bit different. And it's just as one other aside, we haven't spoken about this, but patients who have other types of arthritis, rheumatoid arthritis, psoriatic arthritis, those patients may also sustain joint breakdown and need similar treatments, but that's a little bit different. Those patients are treated by rheumatologists with medications, and then eventually they may get to a point where they need surgical treatment. So, although I'm a surgeon and I enjoy, it's part of my job that I enjoy is surgically repairing people and making them feel better that way, the vast majority of people do not need surgery. And the vast majority of people we try to treat conservatively for extended periods of time prior to any operative intervention. So all the things on the left here, and we'll go through them, are things that we try, and we try to make people feel better. Because honestly, if you have arthritis in your shoulder or really any joint, but you're able to be made to feel better with any of these things, then you don't need an operation. You can live that way with either anti-inflammatory medications, nutritional supplements may help, like things such as glucosamine or chondroitin, physical therapy by maximizing the function of all those muscles and tissues to compensate. And then after those things, sometimes a cortisone injection, which can give relief with respect to inflammation and make you feel better. Hyaluronic acid injections, which are a lubricant or gel type, which traditionally have been used in the knee, but as of last year, Medicare is now paying for it in the shoulder. And then there's a new wave of treatments called biologic treatments, such as platelet-rich plasma, stem cell injections, or even something that I've done a couple of times, which is called fat cell injections, where we actually take fat from your abdomen and inject it into your shoulder, which is supposed to have some regenerative properties. Now, I have to say this. No matter what any doctor tells you, all of those things that I've listed there, nothing makes that arthritis go away. Nothing makes that arthritis reverse. We have no cure in 2020 for arthritis. It doesn't mean that it's not going to feel better, but nothing is going to make those x-rays look better. Nothing is going to make that diagnosis go away. But our goal is to try to make you feel better, not to treat the x-ray, but to treat the patient. So now let's assume someone comes in and they have pain, and we've tried medicine, we've tried therapy, we've tried injections, and they're still like, doctor, I'm miserable, I need something else done. There are a subset of patients that may benefit from a minimally invasive procedure where we go in and we kind of clean things up a little bit, remove the, any loose cartilage, or remove some bone spurs, or, if there is any rotator cuff problem, treat that as well, and kind of clean things up a little bit. Again, you can't treat, you're not going to be able to remove that arthritis. People sometimes ask me, oh, can you go in there and remove the arthritis? That you can't do. You can remove some loose things floating around, but you cannot remove arthritis. That's your diagnosis. That's not going anywhere. It's like a scar. It's going to be there, and we can't remove it. People ask about scraping arthritis. You can't really scrape it. You can smooth it out, and sometimes that will help. But overall, the arthritis is there. But sometimes a minimally invasive procedure in certain cases can give you some relief. The other thing we can do is release tissues to give you better motion and kind of remove any sort of tight tissues that can do that. But then after this procedure, it requires a lot of therapy and time. And as I said, at the end, you're still going to have arthritis. So are there any questions about that? Because that's something that, is only, these are only very specific cases, I think, that would respond to this. But again, I'm just trying to go in order of treatment.
Yeah, well, we are getting questions about actually what you said before, how to avoid surgery. So for example, we have a question here. It says, combined with osteoarthritis and rotator cuff injury, what non-surgical alternatives for pain are available besides Tylenol or Advil type of medication, where NSAIDs and narcotics are not an alternative?
Right. So I will say this, one of the main reasons why people come to me and want to have surgery is because they don't want to be on medication. Because these medications, NSAIDs, even Advil, over-the-counter medications, will have side effects if taken for a prolonged period of time. And if you're on blood thinners, you can't take those medications. No, I don't. I don't put patients on narcotics for these problems, because where's the end? They're going to just take more narcotics, and it's going to be a problem down the line, especially what's going on in society with the opioid crisis and everything else. So, to answer that question, so nutritional supplements, right? I mentioned glucosamine or chondroitin, and I talked about, there are other things. People say turmeric. There are other things that you may read about and things that may give a little bit of relief, but there's not a lot of scientific studies that will say that. So I think that I have no problem with people trying those things. There are some people will say, oh, I take this pill and I feel great, but there's no science to back it up. So I tell patients, look, if you don't want surgery, you have arthritis, try it. There's no downside. Try glucosamine, try turmeric, try these things. Arnica. Arnica is now if you can't take NSAIDs, I would check with your physician, but arnica is a homeopathic anti-inflammatory. That is a dissolvable tablet that some people respond to very well. But again, to answer the question, physical therapy, injections, and then some of these other biologic treatments, which are technically not surgery, can be effective.
Okay. And another question is, what are the treatment options for bone spurs in the shoulder?
So people ask that a lot as well. The bone spurs themselves are very frequently not the problem. The bone spurs are more what we see on an x-ray indicative of the arthritis. So those bone spurs are not the issue. So you don't really need your bone spurs treated. Because those are just how your body responds to arthritis. So really the treatment needs to, in some cases, yes, but for the vast majority, we're not really treating the bone spurs, we're treating that breakdown of the joint surface, which is really where the pain is coming from. The bone spurs usually don't cause pain. It's your body's response to try to stabilize a joint that's not healthy.
How long does it take a rotator cuff injury or tear to heal? And when do you need surgery?
So the problem, hold on, let's go back to this. So the problem is, if you notice on these pictures, the muscles are red. And the reason they're red is because they have blood, and blood helps something heal very well, right? So if you hurt a muscle, usually it heals fine without surgery. But if you look, the white is the rotator cuff tendons that attach, and those are white because they don't have blood, or they have very minimal blood. So when you tear a tendon, whether it's a rotator cuff or it's an Achilles tendon or a quadriceps tendon, those things do not heal. That does not mean you need to have every rotator cuff fixed, but they do not heal. So the treatment for a rotator cuff tear, it depends on your activity level or how acute it is. But if you're younger and you have what's called an acute tear, or it happened due to a fall or trauma, it needs to be fixed surgically. If you're someone who's had a long-standing shoulder problem and a gradually tearing of the rotator cuff, we treat that typically with physical therapy, activity modification, anti-inflammatories, and we try not to operate. But if people don't respond to conservative treatment and they have a rotator cuff tear, the treatment, unfortunately, is surgical repair. Cortisone injections for a rotator cuff tear, a full tear, is not a great idea because it can actually be detrimental, or it can cause the tendon to become weaker. So that's not a good option. So to answer the question, usually it's physical therapy for compensation. It's not going to get the tendon to heal. The only way that tendon is going to heal is surgically.
Okay, that's interesting. Doesn't this happen to a lot of sports people? Like, I always wonder, they get injuries and they always went for surgery. So I was always wondering, why does it have to be surgery?
Well, again, because of the nature of the tissue that has poor blood supply, it's a very common injury. And again, sometimes it's high-level sports people, but as the people on this call know, most of the people on this call are probably not high-level sports people. And a lot of people have rotator cuff problems who are regular people who are just, due to their daily life activities, their rotator cuff becomes damaged. And a wear and tear over time is a very common reason why people have rotator cuff problems. And Sandra, I think a whole talk in the future on rotator cuff injuries would be a great idea, because shoulder arthritis and what we're going to talk about with replacements is very educational, but rotator cuff problems are so debilitating for people and become something that requires treatment, and it's probably the most common thing I see in my office.
Oh, that'll be great. I'm going to send you some dates already.
Sure.
And I'm sure that a lot of people are going to be willing to attend that as well. So rotator cuff coming up. Okay.
Okay.
Cuff. I'm writing it down. Okay. No more questions so far. So if you want to continue with your presentation.
Okay, let's go. So we went through the non-operative treatment a little bit and some of the surgical. And then, so now you come to my office. You've tried all these things. Your shoulders are killing you. Your shoulder's killing you. You still, you have arthritis. We've gotten all the tests. We know what you have. So then there are different kinds. So then you talk about shoulder arthroplasty or a shoulder replacement. And that's, people know about knee replacements and shoulder replacements, but yes, your knee replacements and hip replacements, and yes, your shoulder can be replaced as well. And the good thing is that you don't walk on your arms. So the recovery, and we'll talk about this later, but the recovery for a shoulder replacement is a little bit easier, less painful, and a little quicker. And I will say that, it's becoming more and more common. And I will say this, and people may not, people who've had this will agree. Rotator cuff repairs are more painful than a total shoulder replacement. So people, they think, oh my God, that's a big deal. I don't want that. It is a very, you know, it does, look, surgeries cause pain and then there's a recovery process and we'll get into that. But shoulder replacements are very efficiently done. I've even done them as outpatients in certain people that were, you know, basically maybe one night in the hospital, but we'll go through that. But the type of shoulder replacement depends on whether your rotator cuff is intact or not. And to go back for a sec, so the person on the left has no rotator cuff, as I said before, and the person on the right has a rotator cuff. So I'm going to treat these two patients differently depending on their age and activity level. So if someone has an intact rotator cuff and they failed conservative treatment, then we start to discuss a total shoulder replacement. And there are two kinds that I do. One is a standard shoulder replacement, and one is what's called a bone sparing, which I'll show you, where we do minimally invasive, not minimally invasive, but minimal implants, but that take care of the person's problem. And it depends on the type of person it is and their activity level, but I have patients who have done shoulder replacements who they work for Verizon and they're climbing telephone poles, they like to go to the gym and lift weights, they like to do all these things, and they are able to go back to those activities after surgery. The standard shoulder replacement, which I'll show you in a second, has the limitations of certain activities that probably are not the best. So if you look on the left, that is a shoulder replacement. That is you cut the head off and the ball is removed, which is the diseased ball. You put in a stem in the bone with a ball. And then on the socket, we put a plastic implant that sits on the socket. Now that's a very effective procedure, works very well. The problem is that over time, that socket can get a little loose. And if the more active you are, the less time you're gonna have, the longevity will be decreased in that implant. And the right shows an x-ray of a patient I did that looks like that the same exact thing. So patients have to be educated with respect to what they can and can't do after a shoulder replacement.
Dr. Fong, what's the material for that?
So the plastic is called polyethylene, and the metal is a titanium alloy or cobalt chrome, depending. As just a little thing, there are some patients with metal allergies, and we're able to have implants that satisfy that.
Yeah, that's why I was asking, because of allergies. Okay.
Right. So some people, a small percentage of the population has a nickel allergy. And I have had patients like that, and I've had to use a special implant for that.
And is that, you know, in terms of insurance, if you have to use a different one, does it cost more?
No,
or is it the same?
So a real question, and that's very important, is this covered by insurance? And I think, yes, these are covered. As long as the patient has gone through the conservative treatment, and they've satisfied whatever criteria the insurance company states, then yes, these are covered by insurance. I take most insurance plans, and doctors in the area do, and the hospital stay as well as the surgery itself and the implants are covered by insurance.
Great.
So this now, to go back, this is the standard shoulder replacement that we discussed. This is a procedure that not a lot of people do. I have been doing it more and more over the past few years because, again, as I said, this is a bone sparing. There's just a metal cap with a screw and then a little plastic piece that goes on the socket instead of this bigger plastic piece that goes on top. So the reason why this is important, and my patients have been very happy with this, is that I'm able to take a patient who still wants to be very active and still, or younger, or they have a job that requires a lot of activity and lifting weights and things like that. This is a great implant because after this surgery, patients have zero restrictions. So I'm not going to say you can't do this or can't do that. So you want to do push-ups, you want to do yoga, you can do anything with this implant. This implant requires certain restrictions. So it really depends, and every case is a little bit different. But both of these implants require what's called an intact rotator cuff because they won't function well without it. So again, when we talk about rotator cuff deficiency or people with rotator cuffs that aren't there, whether it's due to long-standing problems or an acute injury, we can do something called a reverse total shoulder replacement. where if you look at this, is that implant I showed before, the standard shoulder replacement. But if you look to the right, the ball is now on the socket, and the socket is now on the where the ball was. Now, why do we do that? Because if you look, the one on the right, the reverse shoulder replacement, allows increased tensioning of the other muscles, the deltoid muscle, to compensate for no rotator cuff, just as in this picture. So if these are different, these are all just different types of reverse shoulder replacements. But if you see the deltoid, the muscle, but by putting this ball and socket in that way, it allows the deltoid to tension more, so that will help you lift your arm up for patients who do not have a rotator cuff, which has become more and more common. This procedure has not been out that long, 20 years, 15, 20 years. Before that, we didn't have options for people, maybe even less, 10 to 15 years. We didn't have options for people. People who had no rotator cuff with arthritis, we basically were like, we don't really have an option for you. This has made such a huge difference, and I do a great amount of these surgeries, because by the time someone gets to me and they're 80 years old or 85 years old and they're miserable, this is the procedure they get, because their rotator cuff is typically not healthy or torn. Patients always ask me, aren't I too old to have a shoulder replacement? And the answer is, I always give them is, no, usually people don't get arthritis until they're older, and this is something that's required. And I have patients, I've done this procedure in people up to the age of 93, 94, because, if you're healthy and you're miserable and you failed that conservative treatment and you want to feel better and live your life and have a better quality of life, then this is a procedure that is very effective.
Are there any contraindications to have this surgery?
So yes, there contraindications for replacement surgery, or reverse shoulder replacement, would be if you have an infection, because that's like any joint replacement. That's just not shoulder. The contraindications are really the same as they would be for any joint replacement: infection, nerve damage. For the reverse shoulder replacement, you need to have a functioning deltoid muscle, because you won't lift your arm up otherwise. So that's very important. There are medical concerns, right? So when a patient comes to me and they want to have a shoulder replacement and they have some underlying medical issues, they'll go to their primary care physician for a workup, and their cardiologist or any other physician. And as long as those physicians have said, sure, this person's healthy enough to have the surgery, minimal risk, no worries, then it's fine. But if there are other things, cardiac issues, lung issues, then those are things that might preclude us from from performing the surgery.
So Anne-Marie, in our audience, is asking, why will someone choose the more restrictive version of the surgery?
You mean the previous, the bones, this one versus this one? That's
Yes.
A good question. So this surgery right here, the bone sparing procedure, requires patients need good bone. Not a lot of people do this surgery because it's technically more difficult. I went to training courses, and I didn't just do this surgery. I had to go to, I went to multiple training courses, cadaver labs, where we practice on cadavers. And this is a very technically difficult surgery, because you're not cutting the ball off. You're just putting a cap on. So to get in there is it's not easy to get in to do this surgery. When you do this surgery, these surgeries aren't easy, and you should at all, but it's easier when you cut the ball off and you can see things a lot better. So this surgery, not a lot of people do it. And I do.
It's more about.
Yeah. So
go ahead.
Right. So it's about experience. You look, shoulder replacement is a lot more difficult than knee replacement surgery or hip replacement surgery. And this is not, I'm not saying this just because I do this. This is, someone who needs a shoulder replacement should make sure that the doctor they're going to does this surgery regularly. You don't want to go to someone who does a couple a year, because this is much more complicated, and it's very delicate, right? So remember, we talked about that shoulder and all that balance. You really need to make sure everything's well balanced. And so because I do this surgery, I do this for a patient with an intact rotator cuff. To answer that question, I do this 80 to 90% of the time, when the patient doesn't need a reverse shoulder replacement, when they need a standard shoulder replacement. And because you're right, why wouldn't I do something when they don't have to have any restrictions? It's a great question.
Yeah. So it's not so much about the patient condition, it's more about the doctor's experience.
Right. The only time I won't do this if a patient has a lot of bone deformity or they have weak bone, because this right here, this has to, for you to do this smaller metal implant, they have to have strong bone underneath it. So if I have a patient who comes in who's 80 years old, who has poor bone quality, I can't do this procedure.
Yeah. Okay. Now we have another question, is what is tendinitis and how do you distinguish between tendinitis and arthritis?
Okay, let's go back here. So arthritis technically means inflammation of the joint, but really what it means is that there's cartilage breakdown in the joint itself that causes pain and inflammation. Tendinitis is inflammation of the tendon. So that means that the tendon itself is inflamed or beaten up a little bit, or even some partial tearing, and that's going to cause pain in these white areas here, or the tendon. That's rotator cuff tendinitis. So sometimes you have both, and sometimes you have one or the other, and it really just depends on each particular case. So how do you tell the difference? Well, X-ray, physical exam, as well as MRIs, things like that. That's how you're going to tell the difference one versus the other. Tendinitis isn't going to give you, doesn't involve joint breakdown or pieces of cartilage flying around or things like that. Tendinitis is with respect to the rotator cuff, means that the tendon is weak, inflamed, and painful.
Will tendinitis eventually heal by itself, or do you require treatment for that as well?
Well, I mean, look, tendinitis, again, there's a spectrum. So you have a rotator cuff problem, and that's either tendinitis, and then it becomes partial tearing, and then full tearing. It doesn't mean if you have tendinitis, you're going to go that way. It just means that tendinitis is the most mild form of rotator cuff problems that we have. And tendinitis may go away on its own with rest and anti-inflammatory medications. It may require physical therapy. It may require cortisone injection. But the research studies show that 95% or more of patients with rotator cuff tendinitis do not need surgery.
Great. Okay. Keep going. We don't have any more questions so far.
Okay. So, when we go to, one thing I wanted to comment on, this reverse shoulder replacement, and again, patients who get to a point where they have severe arthritis of the shoulder, and that, again, I told you that socket is kind of small. It's not like a hip. We have a big socket. There's a lot of deformity that can happen. So patients can develop this flat ball and a deformed socket. So the surgery is very difficult to try to figure that out. So what technology is doing is we're now developing computer navigation, looking at their preoperative tests, whether it's a CAT scan or an MRI, to be able to navigate or to be able to help us more accurately do the surgery. And this is very exciting because, we love new technology, things become more, more specific and much more, hopefully leading to better results. But computer navigation has just started with shoulders, and robotic surgery hasn't yet been there. There is robotic, we have the ability to do robotic knee surgery for replacements, robotic total hip replacements. But shoulders are about to happen, and hopefully within the next year or so, you're going to start to see robotic. It's not the robot's not doing the surgery, by the way. It's the robot. So I don't know what people are imagining, but it's really just that a robot, technically, or an arm, is assisting the surgeon in doing the surgery more specifically to a plan that the surgeon wants to enact. So that's what the computer navigation and the robotic surgery does. And I'm personally very excited about this because all I want to do is do the best we can for our patients. And if this allows us to do a better job with a difficult surgery, it's going to be better for patient outcomes. So that's kind of exciting. And then, again, we talked about this. So this is a reverse shoulder replacement. So you have, again, if you look at the left, you have this stem. The stem is very similar. But then again, instead of the ball being on the stem, you have a cup on the stem, and you have the ball on the socket with these screws that help hold it there. And this is, again, tensions the shoulder differently to allow for better motion, better function. The negative, the restrictions with this are much more significant. This is a procedure that we do for patients with severe arthritis, with no rotator cuff, and the restrictions are more significant. You really can't lift a lot of weight with this. You really shouldn't be lifting more than 10 pounds with this regularly. And this is something where we only really do when patients are, have significant pathology where no other option is available. We do more and more of these because people have bad shoulder problems, and at times we need to do it. But there's just a lot more limitations with this prosthesis than there is with the others that we've just discussed. So what happens afterwards? People go, oh my God, how long am I laid up for? Or what's going to... So as I said, these surgeries, depending on the patient's medical problems, can be done as an outpatient or as an inpatient. And sometimes, patients just stay one day at the most, maybe two at the most, but then they go home. You're in a sling for a few weeks. Now, we can be a little more aggressive with respect to motion of the reverse shoulder replacement because there's no tendon issues we have to watch out for because there's no rotator cuff. The standard shoulder replacement, we have to protect the rotator cuff for a period of time, and then they'll start with therapy. And usually, about 3 months go by, and you might not be perfect at that point, but you'll definitely be lifting the arm and using it, and most of the pain should be gone. So as I said, again, the other things that the reverse shoulder replacement has some limitations with respect to what weight you can press and certain range of motion limitations. So that's pretty much it. So again, I wanted to make it so that's very general. I was joking around with someone when I was doing this, just preparing this, and I said I could talk about one of these subjects for 4 days. So I wanted to make things very broad so that people could ask questions about themselves, and just to give you sort of a broad outline to dispel any myths that you may have, because patients come in to see me, and there's a lot of misconception. There's a lot of not understanding of the rotator cuff. People just don't understand, and it's a complicated group of tendons, but arthritis people don't understand, and unfortunately, people love to listen to their friends, and I always tell them, your friends don't know anything, so it's better to talk to a physician. And you need to find a physician that's willing to try conservative treatment and to make sure that your diagnosis matches your symptoms and your exam, and you develop a plan. And I try not to let anyone leave my office until they fully understand what's wrong with them, they understand what we're trying to do, and to make sure that that person is being taken care of for that person. And what I mean by that is, if I line up 5 people who have osteoarthritis of the shoulder, person A, 1's not going to do anything, 2 wants medication, 3 wants injections, and 4 and 5 need to have an operation tomorrow. So, and they could all have the same x-rays and all studies. So everyone is different because everyone has different pain levels. Everyone has different activities they want to engage in. So you need to make sure that your physician is taking care of you specifically for you. And I think that's very important.
Yeah, I think that most people, and based on the questions that I've received, I see that most people agree with you. They want to avoid surgery. Now, there was something you mentioned briefly about injecting fat from your own body to kind of create a...
Yeah, I touched on, okay. So to talk about the biologics, like I mentioned quickly, yeah. So the biggest wave of research and interest in sports medicine and a lot of orthopedic surgery is how we can improve healing and how we can, somehow get arthritis to stop the process or to treat it in a way that might regenerate cells, and potentially that's what we're moving towards, to be able to regenerate that cartilage. We don't have an answer yet. There's no studies that show whatever you have injected. I don't care what anyone says. There's no studies that show that I'm going to inject you with whatever and it's going to make the cartilage come back. It doesn't exist. And if anyone's told you that, they're not being truthful. However, there are studies where they look at where they inject these biologics, whether it's stem cells, blood that's being spun, or different things that when we inject it, it creates a different environment in your joint that takes the pain away and makes you feel better. So what the fat cells have a lot of blood in them. And there's studies that show that they have a lot of regenerative capabilities. So on 3 occasions, I've done this in 2 shoulders and a knee, where patient comes in, they've already had either surgeries or treatments, and they failed treatments, but they don't want to have a shoulder replacement. So and it costs money. Unfortunately, insurance doesn't, these biologics insurance does not pay for. So I try not, I always discuss it with patients, but I try not to push it, because if I can't give you a very good statistical success rate, I don't like to take someone's, financially it becomes a problem. So, but let's say you said, I don't care how much it costs, what can I do? So what I've done is, a patient is under anesthesia, it's almost like a mini liposuction. I mean, you're not going to notice it that way. No, everyone always gets excited about that, but it's not, everyone was like, oh.
I'm like, oh my God, I'm going to repair my shoulder and get rid of my belly fat.
No. But what we do is we make 2 little small incisions in the abdomen, either in the back or on the flank or in the abdomen. And it takes 15 minutes, and we bring some fat out. And then there's this preparatory process we do where we separate out the fat and the regenerative cells. When we take those cells and inject it into the joint, whatever it may be. And I've done it in 3 patients, and 3 patients are happy. Now, what does that mean? I don't know. That means that they're happy. I don't know whether or not, that person had any regeneration, whether their cells are, I don't know. But I do know that they felt better. And my job is to make people feel better. It's not to,
Of course. Yeah. I'm wondering, because usually I hear that when you have a knee replacement, it's best to do both knees at the same time.
No.
Is that the same case with shoulders?
Okay, so let me answer the first question. Doing both knees at the same time is sort of a difficult, it's a little controversial. On the one hand, you get it done and you're happy and it's all done. But it's a lot of surgery. The risks of that surgery are higher. The morbidity or bad things can happen are higher. It's a lot of stress on your system. And I only do that bilateral knee replacements. I will only do, or both knees at the same time. I will only do if a patient has a lot of deformity where, they're very bow-legged or knock-kneed and they have to do them both because they just have to, or they're younger and very healthy. Patients who are older with any medical problems or very heavy should not do them both at the same time. So that's that. Shoulders, we don't do at the same time because you're going to be laid up for a while, and you're going to be, to have 2 shoulders like this, you're going to be non-functional. So you're going to be very, unless you have a family member that you're really close with, taking care of yourself and your life is going to be very, very difficult. So we don't. We'll do one, and then a few months later, we can do the other one.
Okay. Now we have another question. Is it common for a doctor to make a diagnosis of arthritis or osteoarthritis without x-rays?
You can't.
You cannot.
No.
So if somebody diagnosed you and you didn't have x-rays, you better look for another opinion.
Let me say this. If someone comes in and they're very stiff and they're clicking around and they're creaking and this and that, and let's say they don't want x-rays, I would say you might have arthritis, but you cannot make that diagnosis without a radiologic test. I mean, look, sometimes people get MRIs before they get x-rays, which I think is not a great idea because a lot of times for arthritis, you don't even need an MRI. But you need a test to diagnose it. And if a doctor says you have arthritis, that's impossible to do.
Mm-hmm. Another question. I read that stem cell transplants are still experimental. Is that true?
Right. So all of those biologic treatments, stem cells, platelet-rich plasma, the fat cells, experimental means that we don't have an answer or we don't know. So technically experimental means that, look, there are companies and you can do them very safely. They're FDA approved, but we don't have good data as to whether or not they really work. So to me, that means they're experimental, meaning I can't.
Now, is that good? Is it good data or enough data?
There's not enough data.
I think
So I'll give you an idea. So this is one of the things that interests me the most because I think it's fascinating. We can be able to do these things and make cartilage come back or really treat people with minimal intervention that's going to really help them. It's very interesting and it's very cutting edge research. I went to with the pandemic, we haven't been able to go to conferences, but last year I go to our big academy conference meeting, and I always go to a biologic seminar when I'm there. And I went to a 3-hour seminar last year with some of the top people in the world, research specialists and everything else. For 3 hours, we talked about different types of stem cells and all these things. And at the end, the answer was, we don't know. So the answer is, we don't know. No matter what, and I don't know what everyone tells you, the answer is, we do not know.
We don't.
No.
Oh, wow. Okay. Now, just part B to that question that we were asking before about diagnosing without x-rays. I think if I'm reading this question correctly, what Kimberly's trying to say is that if you can get arthritis or osteoarthritis as a result from a fall.
Yes, so there's three main kinds of osteoarthritis. Okay, one is called primary osteoarthritis. Well, let's say two kinds. There's primary osteoarthritis, which means that due to wear and tear in life or a genetic predisposition, you get arthritis in a joint. Then there's called secondary osteoarthritis, which is in the shoulder would be, as I said before, you get a rotator cuff tear that leads to arthritis, right? So the arthritis happens as a result of that tear. Or something called post-traumatic arthritis, which is what she's referring to, which is I fall down, I break something, or I have a fracture or even a trauma that can accelerate that arthritic process. So the answer is yes, you can get arthritis as a result of trauma. It may take years to come up. It may take 20 years, but yes. Like if someone comes in and says they have shoulder pain, 20 years ago they fell down off a ladder and hurt their shoulder, and they come in and I get an x-ray and it shows arthritis in one shoulder, not the other, it may or may not be related to that fall from 20 years ago, but yes, trauma can certainly cause osteoarthritis in any joint.
Okay. Now, Ruth is asking, what does an MRI show beyond the x-rays?
Okay. So we had those three tests, right? We have x-rays primarily. There are other tests, but x-rays, CAT scans, and MRIs. Mm-hmm. X-rays are a very cheap test that we get in the office primarily as a first level because I may have your answer there, right? So if you come in, your shoulder hurts, you get an x-ray, and if the x-ray shows osteoarthritis, then we start the conservative treatment plan with therapy and medication or injections. You don't need to run and get an MRI at that point. Patients always want it because they think you know more from an MRI. And sometimes yes, sometimes no. It doesn't mean that we need to get MRIs on every problem. CAT scan, three-dimensionally looks at the bone and any bony issues. So sometimes if we need to look at the joint and how the bone is deformed, the CAT scan is very effective. Or sometimes if you want to see if there's a crack in the bone, a CAT scan is very effective. An MRI, which is no radiation in MRI, by the way, X-rays and CAT scans use radiation, MRIs do not. So the MRI is very good about looking at the soft tissues, those muscles, tendons, ligaments, cartilage. That's what an MRI does. So if someone comes in and I'm worried that they have a rotator cuff tear, and their X-rays are negative, then we want to get an MRI to see if that rotator cuff has any damage to it. They tore cartilage or things like that. That's what you're looking for in an MRI. Sometimes I need to know both. I need to know if they have arthritis as well as a rotator cuff problem because that's going to dictate what type of treatment that person may get. But we don't, you don't want to just run and get an MRI when we already have an answer. Someone comes in, we get an X-ray, they have arthritis, that's it. Then we can, start treating it.
So you don't really need to ask for more, you can have just one test and get all your answers from that one test. Yes,
but I always joke around with my patients. I get MRIs for two reasons. One, because I need them to help me diagnose and treat. And the other reason is because patients want them. The patients still have this feeling that that they're not going to be treated properly without an MRI. That's okay, but that's, depends on the doctor. So.
Okay. So you could ask if you don't feel comfortable with one test. I'm just trying to answer the questions that I'm getting here.
So if someone comes in my office and this happens every day, they say, don't you need an MRI to figure out what's wrong with me? And I said, well, sometimes yes, sometimes no, but usually not.
Okay. Usually not. Okay. Yeah. Good. Okay. We actually have only 5 more minutes. My God, we've been busy in this hour. This hour has been running and we've been getting a lot of questions. So definitely we need you back, Dr. Font. So your wish is going to come true. Mine too. So we're going to definitely have another session with you just to let all of our attendees know. Next week, we're going to be talking about hip replacement as well. So we already spoke about knee, shoulder. Next time will be hip. Yes, Dr. Fund?
Sure, yes, that's true. My partner is going to be doing that talk. I would, as I said, I think just listening to the questions, and I think to help any confusion or answer questions. I really think that although I love doing shoulder replacements and any shoulder surgery, really, any rotator cuff problems I think would be a very popular talk because it's so prevalent and it's so common. But if you, whatever you'd like to do that, sure.
Definitely. I'm gonna be emailing you very shortly with some dates to schedule that rotator cuff. Definitely. I think that's
Okay.
a very good talk. And Kimberly saying thank you. You're welcome, Kimberly.
Thank you, everyone. I really appreciate it.
Yes, and just a few announcements. So next week is hip replacement. And then starting January, every first Thursday of the month, we're going to start an obesity prevention program for families. So every first Thursday of each month, we're going to be talking about nutrition and wellness tips on how to reduce weight. And this is not only for adults, this is for children as well. So please help me invite all families and people that you know that might like to lose weight for that. Then after that, we're going to be talking about our new cardiac lab or cath lab, as they say, cancer support, support for diabetes. And again, we have a lot of topics coming. So keep joining us, keep helping others by sharing this information, and that way you help us as well to keep the program going. So thank you to all of our attendees for being with us today. Dr. Fund, I'm fond of you. Thank you so much.
Thank you, everyone, and thank you, Sandra, very much.
It's been great having you. It's been a true pleasure. And we'll talk next week. We'll see each other next week. Thank you very much. Bye-bye.
Thank you.
Bye.